Welcome back, guys. Now we'll talk about diverticular disease. We already discussed about diverticulosis, diverticular bleeding, and diverticulitis. Whenever there is diverticulitis, there is left lower quadrant pain, nausea, vomiting, and fever. This is on the left side. Whenever there is on the right side, right lower quadrant pain, nausea, vomiting, and fever, think of appendicitis as the most important differential diagnosis. Remember, in pregnant patient, whenever there is pain in the right lower quadrant associated with fever and nausea, please do think of appendicitis as one of the most important cause when the liver function tests are not elevated. This is where the trap comes because cholestatic jaundice of pregnancy or involvement of the liver in pregnancy. What did we think of? We thought it could cause pain. Gallstones can also be causing pain in the right upper quadrant. But in pregnancy, what happens is there will be movement of the abdomen appendix to the right upper quadrant. That is why patients with pregnancy presents with right upper quadrant pain, fever, and nausea. Think of appendicitis. Think of endometritis whenever the patient is young. Patient has got pelvic pain. Patient has got right or left iliac pain, and patient is actively bleeding. Patient is actively having menses. Think of endometritis. So these are the most important differential diagnosis for USMLE step 2 questions that you will have to think of. Whenever the examiner asks you about diverticulosis, remember that in the question there will be heavy meat consumption, but in the answers there will be low fiber intake. There will be obesity, which is BMI of more than 30 in the questions for USMLE step 2, and it is associated with smoking. Remember, sigmoid colon is the most important thing you'll have to remember, and it is the right colon that is affected. That is why patients will have right iliac fossa pain when the patient develops diverticulitis. It is basically a painless bleeding, and it is associated with large volume of bleed whenever the patient has got diverticulosis. Whenever there is large volume of bleed that is going on, patients develop hypotension. So I want you to understand that the patient can develop lightheadedness, patient can develop hemodynamic instability in patients with painless bleeding, suggestive of diverticulosis. But when the patient has got low back pain, pelvic pain, retrosternal pain, hypotension, think of retroperitoneal bleeding. The diagnosis for diverticulosis is colonoscopy, which is the most definitive investigation. The confirmatory investigation is colonoscopy. Whenever the patient has got diverticulosis and has got hemorrhage, it most of the cases resolve spontaneously. But whenever the patient has got hemodynamic instability, surgical intervention is the treatment of choice. I want you to understand that that the examiner will test you on the type of the diet you prescribe for patients with diverticulosis. Obviously, we understood that it is the low fiber diet that causes diverticulosis. So you'll have to understand that diets high in fruits and vegetables will help patients with the diverticulosis, please. I want you to understand that the large bleeding that happens in diverticulosis is the key point for differential diagnosis to think of. Whenever there is colonic angiodysplasia, that causes a painless bleeding. Angiodysplasia is a venous part. Angiodysplasias usually happen from a venous anomaly. Whenever there is venous anomaly, it is the low pressure vein. So there will be less bleeding that happens in colonic angiodysplasia. There is this fancy syndrome called Hades syndrome. Most of the textbooks and the question banks did not tell you about Hades syndrome, but I want you to remember that patients with Hades syndrome will have associated aortic valve abnormalities. Aortic valve abnormalities with colonic angiodysplasia is fancily termed as colonic angiodysplasia is fancily termed as Hades syndrome. Hades syndrome. Remember, in Hades syndrome, aortic valve is commonly affected. It causes hemolytic anemia. Please do remember this. In the question, you will find there is decreased hemoglobin. In the question, you will find there is increased hemoglobin. Next, I want you to understand Give me a minute, please. Someone wants to join the Zoom session. Next, I want you to understand that colonic angiodysplasia and aortic valve abnormalities, fancily termed together as Heidi's syndrome. This is easily missed out question. Okay. Next, I want to talk about colon cancer as one of the differential diagnosis for patients who has weight loss, patient who has abdominal pain, and patient who has constipation and diarrhea, which is alternating. Colon cancer is one of the most important differential diagnosis for diverticulosis, but you'll have to understand that that patient will have weight loss, patient will have alternating constipation and diarrhea. Remember, if the patient has got a painless bleeding, hemorrhoids is one most important thing you'll have to do. The first most important investigation for hemorrhoids is direct visualization, and then you will have to do anoscopy. Talking about the diverticulitis, first most important thing is confirmatory is by CT scan, where you will find the focal thickening of the colon wall. But in the question, you will find the examiner mentioning that there is pericolonic fat stranding. Pericolonic fat stranding, whenever you find it, that the diagnosis is diverticulitis. Whatever and whenever you are practicing it, the radiologist will mention that the CT scan shows pericolonic fat stranding. Think of diverticulitis, please. Whenever you diagnose diverticulitis, you will find that colonoscopy must not be done immediately. It is usually done after 4 to 8 weeks, because there is a chance of rupture whenever you do colonoscopy in patients with diverticulitis. That is why CT scan is the investigation of choice. Not only not doing colonoscopy, the CT scan is investigation of choice, but inflammation is easily picked on CT scan. Whenever there is any inflammation in the body, you'll have to choose CT scan as the answer, except for the gallstones, where ultrasound is the most important diagnostic step. Diverticulitis, the treatment I want you to remember that it is the ciprofloxacin and metronidazole. Metronidazole is a luminal antibiotic which acts best in the lumen. That is why metronidazole is the antibiotic of choice for gastrointestinal patients. Remember, bowel rest must be given in diverticulitis. So nil per oral is what you will have to understand. That is why in the question, examiner will mention that it is the IV antibiotics that you will have to use. Next, we talk about diverticulosis, diverticulitis, and next we talk about angiodysplasia presentation. We talked about angiodysplasia presentation. Aortic stenosis will be present associated with Heidi's syndrome as well. One most important thing, the patient will also develop von Willebrand disease as well in angiodysplasia. But remember, angiodysplasia, you will have to select the option of angiodysplasia only if the patient is more than age 60. And if the patient is age 55 associated with aortic stenosis or von Willebrand disease, you will have to select angiodysplasia as the most important option. The diagnosis for angiodysplasia is endoscopy. Whenever the patient has got no symptoms in angiodysplasia, you are not treating the patient, please. But whenever the patient has got anemia or whenever the patient has got bleeding, you will have to first check a full blood count to understand what grade of anemia he's got. And then you can do endoscopy as well. Next, I want you to understand celiac disease. My favorite presentation, young patient with iron deficiency anemia, think of celiac disease. We all know that in part 1 and step 1, we studied that it is because of the immune reaction against gluten diet. So gluten-free diet is the most important step we'll have to follow for celiac disease patients. In the question, when the patient is descending from a European country, think of celiac disease. Whenever the patient is a white patient, think of celiac disease. And whenever the patient is a young patient presenting with chronic diarrhea, presenting with weight loss, presenting with nutritional deficiencies, I want you to understand that it is a celiac disease that is happening. Whenever the patient has got celiac disease, the patient can present with iron deficiency anemia. That's the most important takeaway point from this course regarding celiac disease. The diagnosis of celiac disease is Day-Xylose test, but you will not be asked in the question. The most important and the confirmatory step we will have to do for celiac disease is a biopsy which shows villus atrophy. But before biopsy, what do you have to do and how do you identify that the patient has got celiac disease? It is the IgA anti-tissue transglutaminase and IgA anti-endometrial endomysial antibodies that you will have to do. In European countries, most of the patients will have IgA deficiency. Whenever there is IgA deficiency, you will have the option that the examiner mentions that there is negative serological testing that is identified. So what do you have to do? You'll have to do biopsy where you will find villus atrophy. That is what I want you to remember. But remember, in patients with celiac disease, it is the young patient that presents with all these symptoms. Next, I want you to remember about the malabsorption features. Whenever the patient has got easy bruising, it is because of the vitamin K deficiency that is happening in celiac disease. Whenever the patient presents with pallor, anemia, fatigue, palpitations, dizziness, hypotension, it is the iron deficiency anemia that sets in as a complication of celiac disease. Whenever there is malabsorption of fat and protein, patient will have fatigue and patient will have loss of muscle mass. Remember, whenever there is fat malabsorption, patient will have foul smelling stools, and whenever there is fat malabsorption, there will be floating stools as well. Because pancreatitis is one of the most important complication in celiac disease. In the history, you will find that there will be osteomalacia, bone pain, bone fractures, but these patients will be having a middle-aged celiac disease that points out towards calcium and vitamin D deficiency. Whenever the patient has got thickening of the skin, you will have to select the vitamin A deficiency as one of the most important cause in celiac disease, please. Remember, the complications of the disease is also important whenever you are aiming for 265 or 275. It is the complication that is described in the question. It is not about the main stem. It is about the complication you will have to identify, please. So concentrate on complications, concentrate on differential diagnosis for patients with USMLE Step 2 questions. Very important. Next, we talk about Whipple's disease. Amazing Whipple's disease. First, most important thing is involvement of neurological problems, involvement of cardiology problems, involvement of gastrointestinal problems, points out to Whipple's disease until otherwise proven. Whipple's disease is the option I will select when the patient is in between 50 to 60 years of age because already the examiners have set the questions for Wilson's disease as a young patient presenting with neurology disorders and abdominal disorders. Please do remember Wilson's disease is the diagnosis when you find a question involving psychiatric symptoms and abdominal symptoms. Neuropathy symptoms and abdominal symptoms, Wilson's disease is the cause. But whenever there is abdominal symptoms and neurological symptoms involving the lower limb peripheral neuropathy, lead problems are the most important diagnosis in pediatric patient. Lead poisoning, which causes pure motor neuropathy, please, very important. Lead poisoning, children, ingestion of lead, eating plaques, wall plaques, middle-aged Wilson's disease, elderly age Whipple's disease is what I want you to remember, please. In the question, classic question, the patient will present with the 55-year-old patient presenting with symptoms of malabsorption, weight loss. Now the patient has got joint pains. The joint pains have been present since 4 months, which is migratory, involving the knees, ankles, elbows, shoulders. Now the patient is unable to breathe, developing shortness of breath, raised JVP. Patient has got pedal edema that points out towards the heart failure. The patient was brought in by the partner. The patient was brought in by the Son, because the patient has been having neurological complications such as forgetfulness. And on clinical examination, you find that the patient has got a supranuclear palsy where the patient is unable to move the eyes vertically and has got a vertical gaze palsy. Intermittent clonic sensations and jerks are noticed, that is the myoclonic jerks. All these points towards Whipple's disease, please. And in the question in the stem, they will ask you what is the most important confirmatory or the next step you will have to do. Please select the biopsy because we'll have to identify Trophirima Whipple. Whenever Trophirima Whipple needs to be identified, it is the PAS positive material in the lamina propria of the small intestine that you will have to look for, because biopsy is the ultimate and the confirmatory step for Whipple's disease, please. Next, what is the question? Next, we talk about peptic ulcer disease. Whenever the peptic ulcer disease points out, it is a college student coming up. It is a college student. It is a woman working class. It is a daily job or a manager who is working in an office, presenting with epigastric pain and nausea, missing the breakfast, eats out, has got chronic pain, and is using pain medications, NSAIDs. Very classic. This points out towards peptic ulcer problems. I want you to understand that whenever there is epigastric pain after the onset of meals, or epigastric pain when the stomach is empty, or epigastric pain at night, all these points out towards the duodenal ulcer. Gastric ulcer, you will have to remember that gastric ulcer, middle-aged male patients will have gastric ulcer, and this can point towards gastric carcinoma whenever there is an epigastric mass. Remember this, epigastric mass with weight loss, male patient, history of smoking, gastric cancer is the diagnosis. Epigastric pain after having food, epigastric pain on empty stomach, epigastric pain at night, think of duodenal ulcer. And how do you diagnose peptic ulcer disease? It is the endoscopy that is confirmatory. And when do you get endoscopy? It is only the warning signs when you have. It is the weight loss. It is the night time. It is loss of appetite. You will have to think of whenever you will need to do an endoscopy. Next, we talk about gastropathy. Whenever I talk about gastropathy, one most important question for gastropathy in USMLE Step 2 is acute erosive gastropathy, where there is severe hemorrhagic lesions that are happening. Whenever there is severe hemorrhagic lesions that are happening, people will bleed. So patient presents with acute anemia, patient will present with acute abdomen, patient will present with hematemesis. And also remember the classic question, recently framing question is the patient with stroke, recently admitted to the hospital. The junior doctor have seen this patient admitted with the TIA, and now the patient has been discharged with aspirin 300 mg, but a proton pump cover has not been given. The patient comes to you after 2 weeks completing the course of aspirin 300 mg. Now the patient complains of abdominal pain. Patient does not know what's going on. Patient will complain of a black stool. The partner noticed, or the patient might have noticed. Flushing of the toilet notes that there is black stool. Think of aspirin as the most important cause of acute erosive gastropathy. What do you have to do? Stop aspirin, please. Cover the patient with the PPIs, please. Very important. Classic question. You'll find it in the examination. Next, I want to talk about stress induced ulcer. Stress is not only exam tension, stress is not only changing places, stress is not only about having work tension, workload. It is patients who are admitted to the hospital, it is patients who are undergoing surgery, it is the post operative pain, it is the post operative stress, it is the post operative stroke or post operative anemia that causes a stress induced ulcer. So, in the question, you will find that this middle-aged or elderly patient who has got admitted to the hospital with history of infection now developed the hypotension, points towards the sepsis, points towards the stroke. Patient with coagulopathy or heparin-induced thrombocytopenia recently developed thrombocytes, platelets of decreased, now has got chronic venous sinus thrombosis and arterial sinus thrombosis. I will talk about arterial and venous sinus thrombosis, most important for USMLE step 2 in a minute. But let me complete the question. Coagulopathy, patient has got abdominal pain now presenting with anemia. Patient has got ARDS, patient has developed a whiteout lung, patient is put on a CPAP, patient is put on a positive airway pressure, patient is mechanically ventilated for a severe asthma, patient is ventilated for a COPD, patient is brought in with a traumatic brain injury, patient has got a massive subdural hemorrhage, patient has got a craniotomy done, patient has undergone a neurosurgery referral, patient is on high dose corticosteroids for polymyalgia rheumatica. Patient has received a high dose corticosteroids for temporal arthritis. Now patient developed acute anemia. Patient developed abdominal pain. Think of stress induced ulcers. All these classic examples, all these questions have been asked in the examination. I want you to understand that the presentation of stress induced ulcer will be out of your way. Whenever the patient develops abdominal pain, whenever the patient develops unknown anemia, and the patient is sick in the hospital, whenever the patient is not normal, please do select stress induced ulcer. All these is the classic presentation of stress induced ulcer. The stress induced ulcer is happening because of the hypotension. Whenever there is hypotension, the gut receives less amount of blood. This causes planktonic hypoperfusion. Whenever there is hypoperfusion, the gut can't perform. Whenever the gut can't perform, the gut cries. Whenever the gut cries, it leads to ulcers. It leads to ischemia. This ischemia causes ulcers. Whenever there is ischemia, there will be toxins that are accumulated because the gut toxins are not removed. This causes the removal of the layer by the toxins. The most important toxin that is removing the mucosal layer from the gastrointestinal tract is uremia. So, hypotension is the most important cause of stress induced ulcer. In the question, you will find that the patient has got a history of hypotension. Whenever you think of stress induced ulcer, it is always the proximal part of the stomach in the step 2 CK examination. Sometimes, if the patient is female, you can find duodenal ulcer as well. Whenever there is duodenal ulcer, I'm not talking about stress induced ulcer, but the most common presentation for duodenal ulcer is the examiner wants you to understand that it is a H. pylori infection that causes duodenal ulcer. It is a NSAID that causes duodenal ulcer. I want you to remember this, please. But for stress-induced ulcer, it is mostly the proximal part of the stomach that is involved with history of hypotension, history of shock, sepsis, coagulopathy, trauma, mechanical ventilation, acute asthma, high dose steroids, and everything in medicine. Whatever is causing stress to the patient. Remember, whenever the abdomen cries because of the stress induced ulcer, there will be painless gastrointestinal bleeding because this patient is already in trauma, patient is already in stress, so there will not be any pain. So there will be painless GI bleeding that happens in stress induced ulcer. Whenever there is stress induced ulcer, you will have to treat it with PPIs, you will have to treat it with the H2 blockers. But I also want you to understand treating the cause is the most important step in the treating stress induced ulcer. Next, I want you to understand about dyspepsia. Whenever there is dyspepsia, patient will complain of postprandial pain, postprandial discomfort. After eating food, the patient complains of pain. This is the takeaway point for dyspepsia. We all know that the patient will be on NSAIDs, gastric cancer, esophageal cancer. There can be GERD, which is excessively, which is not controlled. But I also want you to remember one of the most important infectious disorders that causes dyspepsia is H. pylori. Female patients with peptic ulcer disease with H. pylori has got postprandial pain. It is dyspepsia that you will need to answer. And how do you identify dyspepsia or the confirmatory step? It is the urea breath test. That is what you'll have to pick up in the answer. But the most recent investigations showed that stool antigen testing is commonly asked for H. pylori testing. Stool antigen testing. Urea breath test is out of date, darling. It is the stool antigen test that you will have to select. Whenever the patient is an elderly patient and has got an red warning symptoms, what I consider is weight loss as the most important symptom, and persistent gastrointestinal symptoms such as loss of appetite, vomiting, bleeding, or anemia, you will have to do an endoscopy. Remember, in the warning symptoms or warning shots, age is also important. What I classically feel is 57-year-old male patient presenting with anemia, postprandial pain, presenting with weight loss, presenting with persistent vomiting, dysphagia, whatever it is the endoscopy that I want to do in as a next step. Next, I want to talk about the gastroesophageal reflux disease. Most important thing, gastroesophageal reflux disease. First thing is the patient aged more than 50 or not? Because in the question, you will find that patient aged more than 50 has got alarm symptoms. What is the next best step? You do endoscopy. That's it. You find it esophagitis, gastritis, treat esophagitis or gastritis. If it is no esophagitis, no gastritis, nothing, don't do anything. Just send the patient home. But if the patient is more than 50 years, you are not sending the patient home if the endoscopy is normal. And if the patient has got warning symptoms, you will have to identify if the patient has got any other esophageal disorders or gastrointestinal disorders that is causing gastroesophageal reflux disease. Whenever there is no esophagitis in patient with more than 50 years and has got alarming symptoms, I want you to rule out achalasia cardia as the most important differential diagnosis in patients with warning shots and symptoms. I want you to understand that the examiner will frame a question with a diabetic patient mentioning that the patient has got repeated vomiting, the patient will develop gastroparesis. So I want you to understand that gastric scintigraphy is the most important thing you will have to choose. This is when the patient will not have any esophagitis. But what happens when the patient has got esophagitis? Think if the patient is a 64-year-old male patient who is treated for osteoporosis and is taking a pill, the patient has not taken the pill as usual as recommended by the physician, not sat upright, immediately taken the pill, has drank lot of water, immediately eaten, taken food on the empty stomach, you think it is a pill esophagitis. Whenever the patient has got hypothyroidism, type 1 diabetes, celiac disease, think of autoimmune disorders. Think of Sjogren syndrome as one of the differential diagnoses for esophagitis. Think of Crest syndrome whenever you think of these things. I also want you to understand whenever there is a food obstruction, solid food obstruction, easily able to drink water, but the patient has got food obstruction, and on the endoscopy, you find food bolus in the esophagus. You think of eosinophilic esophagitis, please. The eosinophils will be raised in the patient. The patient will be having history of hypersensitivity. Patient will be having history of asthma. But the most important thing I want you to understand for eosinophilic esophagitis is the food bolus that is obstructing in the esophagus. But when the patient drinks water, it is normal. Patient has history of asthma in the question, examiner will tell you the clue. That is what you'll have to identify in eosinophilic esophagitis. Whenever the patient is a smoker, whenever the patient has got repeated GERD, think of Barrett's esophagus as one of the causes when you do an endoscopy for alarming patient who is aged more than 55 and has got an esophagitis. Barrett's esophagus happens at the junction of squamous and the columnar junction. But talking about the GERD in simple disorders, when the patient has not got any alarm symptoms, I personally use 2 weeks of 2 months of proton pump inhibitors. Whenever there is proton pump inhibitors that is happening, I want you to understand you will have to treat the patient only if the patient is not responding to proton pump inhibitors. Whenever the patient is not responding to proton pump inhibitors, I want you to choose the medication, change the medication as the option for the next step. And if the patient GERD symptoms are controlled, you need not do anything. But if the patient has got GERD on repeated things, on repeated change of the medications, I want you to understand that esophageal achalasia is setting in. And whenever you want to do esophageal achalasia or hiatus hernia, you will have to you'll measure the pH in the esophagus. But the problem is, whenever you do treat the patient with PPIs, the pH changes. So the next step is stop PPIs for 2 weeks and then check the pH. This is what you'll find in the examination answer. In the final exam, you will have to stop PPIs and then only you will have to choose measuring the pH because PPIs alter the pH. One most important classic clinical examination, not examination question, but a real life question. The nurse bleeps you saying that the patient has got a NG tube in place and the patient has got an aspirate, but the pH is increased. Doctor, what do I need to do? First, most important question you'll have to ask the nurse is the patient on a PPI? Because PPI changes the pH. PPI changes the gastric pH so that the pH is increased to 6 or 6 to 7. That's the most important thing I want you to remember. Next, I want you to talk about atrophic gastritis. Atrophic gastritis, the classic example is patient presenting with tingling numbness, patient has got B12 deficiency, patient has got a history of type 1 diabetes mellitus, patient has got a history of hypothyroidism, patient has got a history of autoimmune hypothyroidism, patient has got history of celiac disease, patient has got history of vitiligo. Think of autoimmune atrophic gastritis. Think of B12 deficiency. In the question, the examiner tells you that the patient is a female patient. The patient has got other autoimmune conditions, which I listed. The most important thing, the reason the patients develop atrophic gastritis is because of the development of auto antibodies against the parietal cells. Whenever the parietal cell antibody happens, it is because that the patient develops atrophy, patient develops metaplasia of the gastric mucosa. Whenever there is loss of the gastric mucosa, there will be decreased HCl. Whenever there is decreased HCl, there will be gastrin production that is going on. And there will be formation of autoantibodies against intrinsic factor with the patients who have got autoimmune disorder history, and this leads to vitamin B12 deficiency. In the question, whenever the patient has got vitamin B12 deficiency, please look at the MCV. Whenever the patient has got a MCV of more than 100, think of vitamin B12 deficiency. Whenever the patient has got a vitamin B12 deficiency whenever the patient has got an MCV more than 100, think of hypothyroidism, think of autoimmune hypothyroidism, think of celiac disease, think of alcoholism, please. All this I want you to remember. Whenever you think of MCV more than 100, I want you to think that the patient is on phenytoin, patient is on valproate. These can cause macrocytic anemia, please, or at least macrocytosis. We all know that this patient has got hypochlorhydria where the parietal cells are disturbed or disrupted and there will be decreased HCl. But the most important function of the gastrin is to increase the HCl to maintain the gastric atmosphere. Whenever the gastric atmosphere is lost, the gastrin kicks in. So the most important step you'll have to do for atrophic gastritis is find out that the patient has got gastrin levels. Whenever the increase in gastrin levels have been noted, you think of atrophic gastritis as one of the most important thing. I also want you to understand that in autoimmune atrophic gastritis, not only B12 sets in, but there can also be mixed picture that iron deficiency, anemia can also be setting in. Remember, patient with mixed disorders. Macrocytosis is more common than microcytosis because iron deficiency is seen whenever there is concurrent hypochlorhydria. So you will also have to treat iron deficiency anemia. Check iron deficiency anemia as well, along with B12 deficiency. Next, gastroparesis. Remember, gastroparesis sets in whenever the patient is diabetic and has got a long-standing history of diabetes. Most of the patients and most of the students fight that the patient has got diabetes. Patient must have diabetes in order to develop gastroparesis for more than 10 years. No, that is all bullshit. Don't worry about the time frame. It is long-standing diabetes mellitus. When the patient is developing recurrent vomiting, please think of gastroparesis. Examiner is not interested if the patient has got more than 10-year history of diabetes or not. Patient who has got an uncontrolled diabetes, the gastroparesis can set in within 7 years or less than 5 years. So time frame is not important. It is the long-standing diabetes. It is the well-controlled diabetes that sets in given that the patient has got gastroparesis. Remember, in the question, whenever you find scleroderma patient with the recurrent vomiting, please do select gastroparesis as an option, but not stricture. The patient usually presents with abdominal pain, but patient also presents with postprandial vomiting, please. That's the most important thing for gastroparesis, please. The antibiotic of choice you use for gastroparesis is erythromycin in order to stimulate the motilin receptors. That's the most important thing you'll have to remember. Thank you very much. I'll see you in the next link.